కౌరవులు 100 మంది ఉన్న కన్నా పాండవులు 5కి చాలన్నా. అనకుండా 100 మంది లైన్లోకి వచ్చేసి ఏదో ఎక్కడో పనులు చూసుకునే బదులు వినేవాళ్ళు 10 మంది ఉన్న చాలు. ఇన్నోళ్ళు 100 మంది ఆన్ లో ఉండి ఏవో పనులు చూసుకునే బదులు వినేవాళ్ళు 10 మంది ఉంటే చాలన్నా.
సరే, మోహన్ సార్కి ఒక్కసారి ఫోన్ చేయాలా?
చేయండి మరి.
ఒక్కసారి మోహన్ సార్ ఫోన్ చేస్తా. ఒక్క నిమిషం.
మోహన్ రా సార్.
సార్ గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ సార్. ఏంటి నేను చెప్పింది కరెక్టే కదా? డైలాగ్
కరెక్టే సార్, కరెక్టే.
టైం అయినాక 10 మంది ఉన్నా సరే ఆన్ చేయాల్సిందే.
సో దట్ వి కెన్ రిజ్యూమ్ అవర్ డ్యూటీస్.
అంతే కదా,
ఎట్ రైట్ టైం.
అవును.
సో నెక్స్ట్ ఈజ్ అవర్ మెడికవర్స్.
నెక్స్ట్
ఐ థింక్
రెడీ అవుతున్నారా?
రెడీ అవుతున్నాను సార్.
ఏంటి ఎక్మో అది అంటున్నారు సార్? ఎక్మో
ఇప్పుడే డిస్కస్ చేస్తాం మరి.
మెడికవర్ అసలు ఫుల్ రైజింగ్ లో ఉంది సార్. అదే ఎక్మో నెక్స్ట్ ఏమో హెలిప్యాడ్ పెడతారు. ఆల్రెడీ హెలిప్యాడ్ ఉంది కదా మీకు?
హెలిప్యాడ్ ఉంది సార్, పేషెంట్లే లేరు.
ఇది హెలిప్యాడ్ లో వెళ్ళే పేషెంట్లా? అది కూడా వస్తుంది సార్. అదేంటి? మీరే కదా రైజింగ్ స్టార్స్ ఇన్ వైజాగ్, రైట్?
మోహన్ సార్ ఫోన్ ఎత్తట్లేదు.
ఎత్తమని చెప్పానా?
ఎట్లా చెప్తామన్నా? ఎట్లా ఫోన్ మెసేజ్ పెట్టాను నేను.
జాయిన్ అవుతుంటారు సార్, జాయిన్ అవుతున్నాడు బోస్ పౌడే.
సరే స్టార్ట్ చేద్దాం.
విల్ స్టార్ట్ సార్, విల్ స్టార్ట్.
గుడ్ మార్నింగ్ ఆల్ ఆఫ్ యూ. టుడే Dr. Raghu is the fellow of DNB Citizens Hospital, Hyderabad. He is the presenter of today's class. Whenever the patient comes to the casualty in a sepsis or septic shock, how perfectly we are following the guidelines, surveying sepsis guidelines. What is the complaints and how much we are strictly adhere to these guidelines. See the outcome difference is going to talk by Dr. Raghu. Dr. Srinivas is moderating this class today, and I request Dr. Raghu to start the presentation.
Yes, sir. Good morning, sir. Sir, please host cheyale sir. Host cheyandi share chesi.
లేదు కదా, no need of making you host for presentation.
లేదు sir, share content కొడితే only the host can share this in this meeting అన్న.
Okay. I think Bashir is there. Bashir. Hello. Bashir, make Dr. Raghu as the host.
సార్ అవ్వట్లేదు, బట్ నేను స్టార్ట్ చేసా సార్ టాకింగ్.
రఘు
సార్
హోస్ట్ చేశారంట నిన్ను, ఓపెన్ చేయి.
ఏ సార్ ఇప్పుడే వచ్చింది సార్. ఓకే, ఐ విల్ షేర్. So Today, my topic of discussion is today my topic of discussion is how surviving, as everyone knows, surviving sepsis campaign. They have published guidelines since 2004, 2001, 2004, 2008, 2012, 2016, and 2009, 2021. But they, along with guidelines, they started to propose the bundles. What bundle? Bundle is a combined combined effect of a intervention. Whenever we are treating a disease, when we did in a combined way, like 3-4 interventions, like more than 2 interventions at a time, then there is survival benefit. This is the concept of bundle. Bundle is a group of interventions which when they did along with one set, then outcome will be will be good. If we do individually, if we satisfy individual criteria of bundle, there won't be any much outcome difference. That's why they have defined some bundles. That bundle care will decrease the outcome. They showed they did studies which decreased the outcome of the patients. That's why they proposed bundles. First, they proposed bundles in 2004. They surviving sepsis guideline. They proposed in 2004. There are 6 hours and 24 hours bundles. So 6 hours bundles, which contains what we do usually in regular practice, like with whatever amended to 1 hour bundle is a 6 hours bundle in 2004. So they advised that whatever the interventions they proposed to, they have to be done within 6 hours so that outcome will be good. That's why they proposed 6 hour bundle in 2004 and 24 hours bundle, which contained giving corticosteroids, giving C-reactive protein, vitamin C kind of things. They proposed in 2000 for 24 hours bundle, but later stages they found that there is no much benefit with the steroids and vitamin C. That's why they cut off to 24 hours bundle, and they made amendment, and they announced to 2014 guidelines, which in 2013 by bundles they proposed 3 hours and 6 hours bundle. So in 3 hours and 6 hours bundle, we have to do whatever we are doing now. I will go to those bundles in later stages. Now they proposed 3 hours and 6 hours bundle. In later in 2018 amendment, they did that. They made that 3 hour bundle into the 1 hour bundle. So how they showed many studies and many meta-analysis showed that there is a very good outcome when we perform all the interventions, not only single intervention. It's a bundle. What meaning of bundle is that doing all interventions at a time to make a difference in the outcome. So they did many studies, and they observed compliance. By 2013, why they did amendment? So 2013 they made an amendment because of they came to know that 6 hours application of 6 hours bundle is a failure. That's why they made it 3 hours, and they showed very good outcome with 3 hours bundle. Like Kumar et al, when they showed that after 6 hours giving antibiotics will not giving antibiotics after 6 hours will increase the mortality rate by 6.5%, 7% for each hour. Like that, same these bundles are non-application of bundles beyond 6 hours. Non-application of bundles beyond 6 hours, they showed the mortality rate is 6.5% per every hour delay. So remember, for antibiotics, they showed that more than 7%. For sepsis bundles, they showed around 6.5% mortality increase after 6 hours. That's why they made it 3 hours and 6 hours. Today we are going to discuss about relationship between time of emergency department admission and adherence. How adherent we are doing for surveying sepsis campaign by bundle in patients with septic shock. So what is the background? Why they did this study? This is a Korean study. Why why they studied this background, why they did these studies. The Surviving Sepsis campaign, which aims to improve clinical outcomes in patients being treated for sepsis, has established and endorsed international clinical practice guidelines for the management of sepsis or septic shock, as I discussed now. So, for sepsis patients, compliance with SSC bundles has remained the cornerstone for improving quality and clinical outcomes since the publication of the first SSC guideline. So we came to know that applying SSC bundles has very good outcome in the patients. That's why these people want to check how compliant we are doing with compliance with these SSC bundles and how we are going implementing. So therefore, this large multi-center study was conducted to investigate the rate of how much compliance with the SSC 3-hour bundle for the night time and daytime ED admissions, and to investigate the clinical impacts of compliance and mortality in patients with septic shock. Till now, the studies came that how compliant, whether 3 hours bundle is going to give good outcome or not. They did compliance of only 3 hours bundle. But these people did the study. Where is there any difference between nighttime and daytime ED admissions for compliance with the 3 hours bundle? That's why they wanted to check they made this hypothesis. There is a 3-hour bundle is how 3-hour bundle compliance is going to different between nighttime and daytime. So how they did it's an observational study. They did observe no intervention in this group using a prospective multi-center registry of septic shock data provided by the Korean Shock Society. They did prospective. It's a just observational study, no intervention done, and prospective multi-center registry. So they have 11 participating institutions for tertiary teaching hospitals and either regional or local emergency medical center. They enrolled patients from these 11 institutes, and they collected prospective and observational data from this study. Whenever they enter into they maintained a software, and they have collected that registry, and they have told every institution to enter the data regarding shock patient, and they have taken. And study period was from November 2015 to December 2017. So what were the criteria they have included? This study was done before sepsis 3 definition of sepsis. That's why they have considered sepsis 2 definitions, and they did that study only. But basic difference is there is no much intervention difference between sepsis 2 and sepsis 3 treatment part. Only definition is changed, but intervention like fluid resuscitation, lactate, antibiotic were almost same in both the definition. That's why there is no much difference in the outcome. They hypothesize that there won't be any much difference. So intervention is same, only criteria is different. So inclusion criteria, what they included was age more than 18 years and who met the inclusion criteria were enrolled. So what was the inclusion criteria was evidence of refractory hypotension or hyperlactatemia in patients with suspected or confirmed infection. What they considered as a hypotension is SBP less than 90 millimeters of mercury, MAP less than 65, or SBP drop more than 40 mmHg from baseline. What they have taken refractory hypotension is a refractory hypotension. They considered it as even after 30 ml per kg fluid transfusion, and patient requiring vasopressors is considered as a refractory hypotension. And hyperlactatemia, it's a lactate more than 4 millimoles per liter. They consider it as a hyperlactatemia. So evidence of refractory hypotension, like even after fluid resuscitation, patient showing SBP less than 90, MAP less than 65, or SBP drop of more than 40 considered as a hypotension, and hyperlactatemia more than 4 millimoles. They have included. Nowadays also we are using this definition only. So what is the exclusion criteria? Patients who they excluded. So patient who did not meet the inclusion criteria within the 6 hours following ED admission. So if patient is not meeting the criteria of inclusion within 6 hours, like if patient develops any shock after 6 hours, then they excluded the patient. And patient who were transferred from other hospitals. Why? Because we don't know the fluid status, what they have given outside, and it will give bias. That's why they have not taken patients who are transferred from other hospitals. and who were transferred from ED to the other hospital also they excluded. And DNR patients who they don't want resuscitation also excluded from this study. So patients who did not meet 6 hours criteria, who transferred from this other hospital and transferred from this hospital after resuscitation also, they didn't. Why? Because they won't. It's difficult to follow up. They don't have the data for patients. That's why they have excluded those patients and DNR patients. So what study outcomes they have observed? So the primary outcome was defined as a completion of the surviving sepsis campaign 3-hour bundle, which comprises. So primary outcome, how compliant with the they completed SSC 3-hour bundle. So what are the components in the 3-hour bundle are lactate measurements, blood draws for culturing prior to antibiotic administration and prompt administration of broad spectrum antibiotics, appropriate fluid challenge for patients with a mean arterial pressure less than 65 and serum lactate concentration of 4 millimoles per liter or greater. Like lactate, we have to now 1-hour bundle includes 5 components, but this has remeasure of lactate is not there in this 3-hour bundle. And they did lactate measurement, they did the blood draws for culturing prior to antibiotic, administration of broad spectrum antibiotics, and appropriate fluid challenge if MAP is less than 65 and lactate concentration more than 4 millimoles per liter. But now our component, we have to start along with fluid resuscitation. We have to give vasopressors also in 1-hour bundle. So what secondary outcomes? Secondary outcome they did was adherence to the individual components of the SSC bundle. So how they each bundle, like there are these 4 components are there. How compliant, which component they are addressing early, which component they are not able to address. They did this study also. So how adherent to the individual components of the SSC3. Even primary outcome they did is as a whole they did 3-hour bundle complex. In secondary outcome, they observed how each individual component of the 3-hour bundle they observed. So the compliance rate to the SSC3 bundle was calculated based on the time interval of arrival in the ED. In addition, in hospital and 28 mortality were also analyzed according to the compliance with the SSC 3-hour bundle. So they did each component of the SSC bundle, and they did study also for mortality in hospital and 28-day mortality. So what statistical analysis they used was univariable analysis were conducted to evaluate the relationship between clinical characteristics and adherence to the individual components of the SSC bundle. But univariable analysis is the analysis of a single variant, like patient's heart rate. So univariable analysis of this heart rate of compliant group, non-compliant group. Like they did univariable analysis and to identify the independent factors affecting compliance with individual components of the bundle. Right. Multivariable logistic regression analysis. So multivariable logistic regression analysis is comparing the 2 covariates. So there are 2 different univariate analysis for compared as a single as compared. That is called as multivariable logistic regression. So Kaplan-Meier, as everyone knows, Kaplan-Meier survival course and the long-run test were used to identify significant relationships between the adherence to the SSC 3-hour bundle and in-hospital mortality and 28-day mortality. So what they did subgroup analysis was, even they did subgroup analysis, those patients who have SOFA score less than 8 or SOFA score more than or equal to 8, and lactate level less than 4 or lactate level more than 4 also, they did subgroup analysis. So more sicker, less sicker patients they observed. They did subgroup analysis for more sicker and less sicker, and application of compliance of the bundle in the daytime and night time. They compared this thing also. So results, coming to the results, what how many cases, how many patients they have enrolled was 2,250. They have collected data of 2,250 patients from shock registry, and they excluded around 221 patients. Why? Because admission to enrollment time was more than 6 hours. They excluded that patient. and MAP was less than when they have taken MAP 65 to 70, that cases also they have excluded. So they included total patients was 2049, and in the daytime and nighttime they divided from 9 to 7 is the daytime, night 7 o'clock to morning 9 o'clock they consider it as a nighttime arrival. So 6:59 was the cutoff time for the patients. So included patients was daytime arrival was 1180 and nighttime arrival was 869. In this 28-day non-survivors was 240, that is 21% of daytime arrival were dead, and survival was 78.7% survival there in daytime arrival, and nighttime arrival there is 22.2% non-survivors and 77.8% survivors were there at 28-day, and non-survivors at hospital discharge also same for both the groups. So this is a comparison of demographic and clinical characteristics for daytime versus nighttime admission of all patients admitted to the emergency department and those with the septic shock. There is no much difference like age, sex, SOFA scores, Apache scores, and initial vital signs. There nothing was significant. Even past medical history also nothing significant in when compared daytime and nighttime admissions. And this is the source of infection like GI tract and urinary tract was more in the nighttime group. GI tract and urinary tract infection was more. Other infections are almost same in both the groups. So this is the box showing volume of patients to doctor ratio, patients to nurse ratio, and number of patients per hour, and ratio of patients per hour. They calculated everything came to significant. Like patients to doctor ratio was more in the morning. That is more patients compared to night time in the morning. That came significant. And patients to nurse ratio also very less, more in the morning time. That is more patients are for less healthcare staff is available for more patients. Like there are 1.25 patients per doctor in the morning, per doctor only 1.1 patient in the night. Like 0.95 sisters, 0.95 patients per one nurse in the morning, but it is 0.73 in the night. So number of patients per hour, ratio of patients per hour was more in the morning. That is 5.2% of patients in the morning and 3.8% in the night. And clinical outcome they observed, this is a secondary outcome, they observed 28-day mortality was, as I told in the previous slide, it is 21.3% in the daytime group and 181 in the nighttime group. But even though it is showing around 1% more in nighttime, but it is not statistically significant. This 0.634, p-value is 0.634, which is not statistically significant. And this indicates there is no mortality difference in the day and nighttime admissions. So in-hospital mortality was also not significant, even though it is showing around 0.5% more in nighttime group, it is not statistically significant. So ICU admission rate also almost equal in both the groups. P-value is 0.96. This is almost equal percentage in both the groups. So when there is no difference in the mortality when patients are admitted in the morning or night time. So please remember this thing. There is no much clinical outcome from. According to this study, there is no clear mortality difference between admissions in the daytime and night time. So this is the graph showing bar diagram along with chart, flow chart. It is showing that there is each hour how much is the patient doctor ratio and what is the mortality. It is showing. Like from this study, there is increased adherence to full bundle at night around midnight, 3 o'clock. There is a good adherence of the full SSC bundle, and there is very less adherence to the SSC bundle was in the morning around 11 o'clock. Like maybe at that time there is increased patient load. That's why the very less adherence at 11 o'clock. In the morning 9 o'clock, there is a good around 37-38% adherence to the SSC bundle is there. And doctor nurse patient doctor ratio is very more at 7 around. It starts around 7 o'clock. From 7 to 10 o'clock, there is high patient to doctor ratio. So there are more patients for each doctor at 7 to 10. And mortality was, even though it is showing little bit higher, as I explained in the table above, there is no statistical significance. Even though it is look like there is more death in the night shift, but it is not statistically significant. And patient to doctor ratio was very less at around 1 to 6 o'clock. That's why maybe that is the reason very good adherence to the bundle at that time. Midnight around 1 o'clock to 4 o'clock, there is a very good compliance compared to daytime. So there was a significant difference in the patient medical staff ratio, daytime and nighttime, resulting in the higher patient doctor ratio and patient nurse ratio at the daytime compared to the nighttime. As I told, it is a statistically significant also, 0.001. So the univariable logistic regression analysis showed that nighttime admission was associated with higher adherence of the, and they did univariable. They, as I told, the secondary outcome was they observed each adherence to the each component of the SSC bundle. So what they observed was the univariable logistic regression analysis showed the univariable. So they did only one component of the SSC bundle. That's why they showed it. Univariable logistic regression analysis showed that nighttime admission was associated with higher adherence of rapid fluid resuscitation, timely antibiotics administration, and completion of SSC bundle. So three components like rapid fluid resuscitation was done very good in nighttime, and antibiotics were given at right time in the night time. So and completion of SSC bundle also very compliant in the night time. So out of the four components, there is a rapid fluid resuscitation and timely antibiotics, and completion of SSC bundle was very good at night time. And nighttime admission was not associated with timely blood sample collection. Sample collection was delayed in the night, and vasopressor administration and lactate measurement was delayed in the night time. So remember this thing, and so that it helps to correct in our setup. That's why I'm stressing this point. So there is even nighttime fluid resuscitation and antibiotics are compliant, but sample collection and vasopressor administration was delayed. So that if we see in our hospitals, it increases our quality. That's why I'm stressing this point. And the multivariable logistic regression analysis, night admissions exhibited higher odds for antibiotics within 3 hours. So, and with the complete SSC bundle after adjusting for potential confound. So this, if we see the table here, so timely antibiotic administration was a very good at night admission versus day admission. It is 1.326, that is 0.005 p-value. So what is the meaning of odds ratio is? Odds ratio a confidence interval when it doesn't include 1, so it is a significant. Like out of patients 1.088 and 1.617, it indicates that around 59 patients will get benefit from this, and only 12 patients may, only 8 patients may get harm with this intervention. So timely antibiotic administration was very good. Odds ratio indicates there is a ratio of the outcome in intervention and ratio outcome in the non-intervention group, that is indicated by the odds ratio. And confidence interval, it doesn't include 1, so it is more than 1. So timely antibiotic administration was significantly better in night admission. So even for SSC completion bundle also very good in the night admission. They adjusted odds ratio is 1.368, and 95% confidence interval 1.115 minus 1.115 to 1.678, and p-value is 0.003. And this itself indicates that is a very good compliance and very good antibiotic administration in the night compared to. So only daytime, because of lack of antibiotic administration, that is lacking in the completion of the SSC bundle. So this is the adherence of full SSC bundle. Like for patients, there was significant and independent association between performance rate of complete SSC 3-hour bundle and nighttime admission in SOFA scores less than 8 and lactate less than 4 with relatively lower clinical severity. So patients who have less SOFA score and less lactate, the intervention was delayed in the nighttime compared to the patient with the clinical severity more, like SOFA score more than 8 and lactate more than 4. So what this meaning of this thing is, less severe sick patients are less treated in the night time compared to the more sick patients. So more sick patients are equally treated in the daytime and night time. So but in the night time, there is maybe SOFA score less than 8 and lactate were not treated very well. Maybe it is because of lack of expertise at the night time. Maybe this is the error in this study. So maybe lack of expertise, lack of identification of progression of the disease in the night time, less expertise in the night time, that may lead to this confounding. So a total of 452 patients died within the 28 days following ED admission, and 476 died while hospitalized, 20% in the 28 day and 21.2% in the hospital. And the univariable analysis showed significant differences in the adherence of complete SSC bundle who did and did not develop 28-day and in hospital mortality. So what this analysis showed, they found that adherence to the complete SSC bundle outcome was good compared to the patient who did not fulfill the SSC bundle completion. So in the multivariate Cox proportional hazards regression analysis, this is a multivariate only. The hazard ratios of the intervention bundle for 28-day mortality and in-hospital mortality was 0.750 and 0.714 respectively for the complete SSC 3-hour bundle, and 0.742 respectively for the timely administration of antibiotic. So what is same what we discussed in the later, what I showed in the this thing indicates same. So there is a very this thing. So antibiotic administration and completion of the SSC bundle will give good outcome. This is what this is showed. So this is the plot showing that although daytime and nighttime ED admission did not differ in terms of mortality, timely address the complete. So they did. First graph, what is the left side? Left side there is survival probability. A is the 28-day mortality, B is the in-hospital mortality. So A showed that completion of SSC bundle will lifespan will be increased, and the survival probability is when at 0 it is 1, it is decreased up to 0.7 after 28 days in case of who completed SSC bundle. But in case of non-completion of SSC bundle, it came around 8. So it indicates that survival probabilities out of 100 patients, around more than 90 patients survived if we complete SSC bundle. Only 10% mortality will be there if we complete SSC bundle in 3 hours. But when there is a survival rate is decreased to around 75% when we did not complete the 3-hour bundle. So same in-hospital mortality also, there is around 85% survival rate with completion of SSC bundle, and when it decreased to around 75% if we did not complete the SSC bundle within 3 hours. So I think you people understood that. So survival will be better if we complete SSC bundle within 3 hours. So what are the limitations of this study is missing data, as it is a registry. From the registry they have collected this data. There can be increased missing data can be there, and retrospectively analyze data, potential confounding factors, and to clearly determine whether the relationship between variables were causal. So it is a retrospective data. They don't know what made the difference between the groups, and potential change in ratio of patient and doctor in weekdays and weekends. They have taken only nighttime and daytime admission data, but there can be chances like holidays or weekends or weekdays. there can be difference in the patient-doctor ratio. Like in weekends, there will be less flow of the patients even in the morning. So they have not taken that data. So it can be a confounding factor. And another indicators related to the medical staff workload, such as churn time, churn rate, occupancy rate, and the level of experience of individual medical staff. Some what are the experienced patients who staff who are in the night time? We don't know. In the night time or daytime, we don't know. And this workload and what are the duty timings for them also, we don't know. So maybe that makes a difference. If that is one of the limitation of the study. So what conclusion they made was, septic shock patient admitted to the ED during the daytime exhibited lower sepsis bundle compliance than those admitted at the night. The higher number of admitted patients and the higher patients to medical staff ratio during daytime may be the factors that are responsible for lowering the compliance. That is what they concluded, that higher number of admitted patients and higher patients to medical staff ratio, that is more patients for each medical staff in the daytime, that may be led to the decreased compliance of the bundle. Thank you.
Thank you, Raghu. Very nice presentation. The
Thank you.
final conclusion looks funny that one thing is the night admissions complaints is more, and another thing, daytime number of staff and doctors availability is more. That's why the complaints is less. I didn't understand this one.
Sir, patients are more in the morning, sir, compared to night time. There are more patients in the night, more patients in the morning time.
But more staff also available in the morning, no? You said?
Even then, when they compare patient-doctor ratio, that is very much more in the morning time compared to night time.
Okay.
That's why they showed, sir, 1.95 patients per doctor in the morning. That it led to 1.4 in the night time. That indicates there is patient load is more in the morning compared to staff. There is more patients in the morning. Night time there is less patients compared to the
See, Raghu,
sir.
ratio is more means more number of nurses are there, or
No,
less
sir.
number
Ratio more means nominator patients uన్నారు, sir. Patients divided by nurses.
So patient divided by nurses. So patient divided by nurses ante suppose example 10 patients 2 nurses ante 5 avutadi. If 5 patients 2 nurses ante 2.5.
Yes.
So lower is the ratio, the better is the nursing and doctors. So
yes, sir.
when
Yes,
the patient in the morning is the patients in the morning were higher when compared with the staff.
Yes, sir.
The night the patients were less and staff were adequate. Probably we can say it as an adequate.
Yes, sir.
And here the resuscitation was done well, but lactate and cultures were not done, no?
Yes, sir.
Night?
Both are not cultures.
So that is one of the predictor for the mortality. Lactate
measurement. Yeah.
Why it is not done in the daytime?
Sir,
night lactate.
Sir, daytime బానే సార్, నైట్ టైం అవ్వలేదు సార్ అది.
లాక్టేట్ ఇంటర్ప్రిటేషన్ రిసస్టేషన్ చేశారు కానీ మన లాక్టేట్ ఇంటర్ప్రిటేషన్
చేయలేదా? కల్చర్స్
అన్నారు. కల్చర్స్
but they followed the bundles, right?
Yes, sir. Completion of bundle was better in the night time, but sample only they univariable logistic regression. Each component when they observe,
so
sir, చెప్పండి sir.
So this says that whenever whether in the day or night, if you have a proper protocols in place and bundles implementation is there, training is a continuous thing, and update your team, I think there will not be a more day and night difference in the care, which is required both for the emergency and also for the ICUs. Yeah, please
And,
go.
and another issue, what they observed, nighttime GI cases, GI sepsis and urosepsis cases are more when compared to daytime. Any reason for that?
Yes, sir. Don't know, sir. They didn't give any reason. Maybe they thought that if any GI issues are there, it will get resolved. That's why they didn't come.
Okay. Any questions?
అదే నైట్ టైం ఎక్కువ ఏంటి డేవిడ్ నాకు అర్థం అవ్వలేదు.
Night time gastrointestinal sepsis and urosepsis cases are more when compared to daytime.
Sir, with demographic data, when they showed demographic data, they found that GI infection and urosepsis patients were reported more in the night time compared to the daytime.
థ్యాంక్ యూ.
So, Raghu,
Sir,
how did they complete the resuscitation bundle more percentage without doing much of lactate?
సార్ అది అంత ఆ డీటెయిల్స్ అయితే కరెక్ట్ ఇవ్వలేదు సార్. వాడైతే ఓన్లీ ఈ పాయింట్స్ ఇచ్చారు, రిజల్ట్స్ లో ఇది ఇచ్చారు, కానీ అది వాళ్ళు అది చేయకుండా కంప్లీషన్ ఎట్లా చేసిండ్రు అనేది చెప్పలేదు సార్.
That is one of the most important, lactate.
అవును సార్, అవును.
Fluid
That is one of the
resuscitation.
components.
Antibiotics
Yes,
also they have given it. On what basis he is
Yeah.
giving a fluid resuscitation? Lactate is one of the marker, of course. Blood
అవును
pressure
సార్. వితౌట్ దట్ హౌ దే గివెన్ ఫ్లూయిడ్
అంటే బ్లడ్ ప్రెషర్ ఉంది కదా, సెప్టిక్ షాక్ తో రిసస్టేట్ చేస్తున్నాడు. బట్ లాక్టేట్, see, overall there is a bundle, they are following the bundle, but in that univariate analysis they found that lactate is less monitored in the night.
Yes.
Did they purposefully not done the lactate and cultures or
No sir, no sir. అంటే నైట్ టైం స్టాఫ్ చేయలేదు అని అనిపిస్తుంది.
అంటే అందరు
మనలాంటి వాళ్ళే వాళ్ళు కూడా
ఇట్ ఈస్ a significant thing అంతే.
మనలాంటి వాళ్ళే వాళ్ళు
significant, but
ఏమన్నా
Usually we'll get lactate now, David. Srinivas in ABG, most of the centers.
అంటే మరి
అంటే ఇట్ ఈస్ నాట్ లైక్ మోహన్ రావు సార్,
Yeah.
it is not like doing ABG, but the intervention not done. Taking ABG or they doing lactate, there is no much difference. No, that's the intervention they didn't do.
Yeah.
They didn't.
అంటే లాక్టేట్ క్లియరెన్స్ డాక్యుమెంట్ చేయాలి కదా.
Yes.
Okay, but purposeful ga cheyaleda or
Yeah.
it is not the matter of doing. No, it is not the issue at all.
Yeah.
Anta intervention. Why
yeah.
they didn't do?
Actually, each hospital having their protocols and staff experience and doctors and everything matters. Actually, we can't replicate into our ICs. So my one suggestion is Srinivas and David and Dr. Mohan Maharaj sir. Can you do same? Means take this kind of study for a short duration in our ICUs or 6 ICUs
Without doing lactate and blood cultures?
No, they're doing everything. The septic protocols.
Okay.
Serving sepsis guidelines. See what lackness is happening, so that we can rectify in coming days in our ICs. Srinivas, we send any protocol, we'll implement it. At least in
మోహన్ సార్,
Raghu దగ్గర
Mohan Rao
data
sir.
ఉందా?
మోహన్ రావు
Raghu?
సార్,
yes, చెప్పండి సార్.
You have any data? I mean the
audit your all this one, sir.
Yeah.
Your bundles you have to audit, and in that you can do a daytime and nighttime also.
Yes.
Time batti. And this is one of the two way we can do it in the daytime, nighttime complaints కూడా
Yes sir, Srinu, అది కాదు, ఒక మన 6 ICs తీసుకుంటే comparative and competition type of struggles. Our people also will do like that.
Yes.
Anna
Okay, just for 1 month. If you get 10 cases also is enough.
Yes.
My main doubt here is whatever the intervention done in the ED emergency department and the ED people are managing these cases. Okay,
Yeah.
Intensive. We don't know whether they are following or not properly.
Yes.
They are
So
not
that we
charging
can
you.
inspect our ED. So that we can instruct our ER people also after 1 month by seeing that it is data.
You have to give the protocol list of protocol and guidelines to follow strictly and give the data after 1 month or
No, first, Mohan Rao sir, first what we will
Yes.
do is we will implement a protocol because
Yes.
as per the 2021 guidelines, we'll
Yes,
prepare a
yes.
protocol and put in place because most of them are based on the 2016 guidelines. So now
Yes.
the guidelines has changed. We'll put
Yes.
as per 2021 and then we will implement it. We'll come to
Yes.
that in a week's time, like that, and then we can implement.
Sir, Mohan sir, your feedback.
I have joined late, really sorry. It's very nice. No, only thing is regarding this, you have to make a protocol and do it.
Raghu, do you have any list, checklist of this protocol? So that we
చెక్
can.
లిస్ట్ అంటే అదే సార్ 1 hour బండిల్ 3 hour బండిల్ ఉన్నాయి సార్.
అదే అవన్నీ ఒక ఫార్మెట్ లాగా ఇస్తే.
Okay sir, sure.
Prepare and a format and give that. I mean, when patient admit, what is the vital data and what first intervention, second intervention,
Sure,
third
sure.
intervention, first hour, second hour, third hour, up to 6 hours. So what are the
Sure sir, we'll
things
do.
to be done? What are the things to be followed as per the sepsis campaign protocol? So if you prepare
Sure,
one
sure.
chart, we can give to all our casualties and ICUs, and we can analyze
Sure.
that. You prepare that.
Sure sir, sure. I'll prepare.
Jekkina?
Yes sir. Yes sir.
మీరు వాట్సాప్ లో పంపిస్తే మేము we can take a printout and distribute in all.
No, what we will do is whatever we prepared, we'll share in the group.
Yeah.
Once everybody agrees, you can
Yes.
edit it, and then we will go ahead forward.
అలాగే, that is better.
Sir, we'll have a Google Sheet, sir. Google Sheet directly you can enter from anywhere. I will make it and I will give you. We'll discuss it.
Okay.
Yeah, that it is very good, Raghu.
Yes sir.
Any questions or suggestions from the audience?
ఇప్పటి వరకు ఎవరి దగ్గర ఉందా అంటే యాజ్ పర్ 2021 ఎనీ ప్రోటోకాల్ ఇస్ దేర్ కేర్ హాస్పిటల్ గానీ లేదా మన ఎన్ఆర్ఐ లో గానీ
అంటే రిటర్న్ లాగా కాదు, వీఆర్ ఫాలోయింగ్, థింకింగ్ దట్ వీఆర్ ఫాలోయింగ్.
మేడం
హలో,
గుడ్ మార్నింగ్ మేడం.
మార్నింగ్. ఈఆర్ లో సెప్సిస్ పాత్వే ఫామ్ ఉంటది కదా శ్రీనివాస్, సో దే ఆర్ ఫాలోయింగ్ దట్ ఈఆర్ లో.
That is very old, madam. That is very old one. 15 years back, 10 years back, I think.
No. ఎప్పటికప్పుడు సెప్సిస్ పాత్వేది కొత్తదే ఫాలో అవుతున్నారు.
మీరు ఒకసారి షేర్ చేయగలరా
మేడం? ఒకసారి మీరు అది షేర్ చేయండి మేడం.
నేను చెక్ చేస్తాను, బట్ యాజ్ ఫార్ యాజ్ ఐ నో మా దగ్గర బ్లడ్స్, కల్చర్స్ అన్ని వెళ్ళిపోతున్నాయి నైటే. కల్చర్స్, బ్లడ్స్ వాటికైతే లేట్ డిలే అవ్వట్లేదు.
దాని గురించి కాదు, ఆ సెప్సిస్ పాత్వే వాట్ యు ఆర్, ఐ నో దట్. నా దగ్గర ఉంది అది నేను నాకిల్లో కూడా మాడిఫై చేసి పెట్టాను. దేర్ ఆర్ 4 pages ఆఫ్ సెప్సిస్ పాత్వే. కానీ అది 10 years నుంచి, ఆ తర్వాత దాన్ని మాడిఫై చేశారో లేదో నాకు గుర్తులేదు మేడం. ఒకసారి షేర్ చేయండి,
చెక్ చేస్తాను.
చూసి అది లేటెస్ట్ కాదో ఒకసారి చూడండి మేడం.
షూర్. ఓకే, రైట్.
ఎనీ డౌట్స్?
కొంచెం ఎక్మా గురించి మాట్లాడమని చెప్పరా?
యా, శ్రీనివాస్, ఎం శ్రీనివాస్.
సార్ మార్నింగ్.
యా,
మోహన్ సార్ ఒకసారి ఇనిషియేట్ చేయండి, ఐ విల్ కంటిన్యూ. హలో మోహన్ సార్.
ఏం లేదు, యాక్చువల్ గా there is a ECMO workshop which we want to do in Visakhapatnam, and మామూలుగా ప్రజెంట్ గా ఫోర్టిస్ లేదంటే దుబాయ్, క్లీవ్లాండ్ లేదా ప్యారిస్, ఇక్కడ అన్ని చోట్ల కూడా కండక్ట్ చేస్తున్నారు హ్యాండ్స్ ఆన్ ట్రైనింగ్ వర్క్ షాప్ ఇన్ ECMO. సో అలాంటిది వైజాగ్ లో కండక్ట్ చేయాలని చెప్పి అనుకుంటున్నాం. అండ్ విత్ హెల్ప్ ఆఫ్ శ్రీనివాస్ అండ్ హిస్ టీమ్, ఫ్రెండ్స్, సీనియర్స్ ఉంటే, సో దే విల్లింగ్ టు కమ్ అండ్ డూ, అండ్ వెరీ వెరీ నైస్ అండ్ పాజిటివ్, హ్యాపీ దట్ దే వాంట్ టు కమ్ అండ్ డూ. సో ఒక 15 మంది ఉంటే మనకు వర్కౌట్ అవుతుంది, బికాస్ ఇట్ కెన్ రెడ్యూస్ ఆల్ అవర్ ట్రావెల్ కాస్ట్, డ్యూరేషన్ ఆఫ్ టైమ్, ఎక్స్పెండిచర్, ఎవ్రీథింగ్ విల్ కమ్ డౌన్ బికాస్ ఇఫ్ యూ డూ ఇట్ హియర్. సో ఫైనల్లీ దట్స్ గుడ్ కదా, చాలా బాగుంటుందనే ఉద్దేశంతో వి థాట్ వి విల్ స్టార్ట్. To start, we need to have around 15 people, and it takes around 4 months to 6 months to plan it out and have a logistics and understanding. And we need to take from the company mannequin and ECMO machine అడగాలి, వాడు ఏమన్నా స్పాన్సర్ ఏమన్నా కొంత చేయగలడేమో, సో దట్ ఇట్ ఈస్ ఈజీ ఫర్ ఆల్ ఆఫ్ అస్. అండ్ ఇఫ్ యూర్ ఆల్ అట్లీస్ట్ ఒక 10 మంది అన్న మన వాళ్ళు ఉంటే, దెన్ మిగిలిన బయట వాళ్ళు ఒక 5 మంది అన్న వస్తే సరిపోతుందని అనుకుంటున్నాను. మీన్ వైల్, if we prepare for that, we can think about some discussion about the theory or discussion about ECMOS little more, because experienced people బాగానే ఉన్నారు కదా, మన దగ్గర పెట్టాడు, కొన్ని సతీష్ పెట్టాడు, చాలా రోజులు వాళ్ళు పెట్టాడు, కాబట్టి వీ కెన్ హ్యావ్ డిస్కషన్.
లెఫ్ట్ తీసి ఆఫ్ చేసి మీటింగ్ అయిన తర్వాత మనకు సిగ్నల్స్ రా ఇక్కడ లెఫ్ట్ తీసి
అని
చెప్పండి సార్.
that's from my side.
ఓకే
And
Sir, good morning. Actually, there are ఇప్పుడు దాకా సర్టిఫైడ్, ఐ మీన్ డిప్లొమా సర్టిఫికెట్ ఇచ్చే హ్యాండ్స్ ఆన్ ట్రైనింగ్ ఉండే కోర్సెస్. One is from Lapiti, Paris, where the Eolia trial has been done. That is one of the center where there is a 7-day program, which costs around 1,25,000 or 1,30,000 for the 7-day, and they'll give you a diploma certificate with a hands-on training. And second is an Australian course, which is a 6 months based course, I think. And it will take much time. Adi akkadiki velli cheyalsindi, we have to spend there, I think 3 months or 6 months. Third course, recently Fortis has started, since last year they have started a 3-day program, which is costing around 85,000 for 3 days. By I think Sandeep Diwan and team.
5,000 per head,
Per head, sir.
program?
Per head.
Okay.
So with their hands on ECMO annappudu, they take, because circuit and everything, it costs a lot. So recently, ఇప్పుడు ఏంటంటే Cleveland Clinic has started starting their program, and official flyers gani, official information gani yet to release. They haven't released, but the program has been decided, because we have colleagues and my senior over there, and I got the information for 3-day program. So after many discussions, what we have found out is they are also okay with coming over here, and if the finances work out. And if we talk about Cleveland, it is a center where like around 60 to 70 ECMOs in an average per year they'll put. It is an ECMO center, and during the COVID times it went up to 100 per year. Their survival rate during the COVID season is around 96 to 98%. Patients were discharged out of VV ECMO, and whatever time maybe they have put it, like even at the 25th day, even at the 20th day, even at the 15th day. 36 ECMOs they have put in the second season, and of which 35 patients were discharged. And average VA ECMO survival was around 85% from their center. And they have a very good protocol. So simultaneously, they wanted to start a program to establish at a smaller centers. In the sense, they wanted to train, and they wanted to they wanted to go to the smaller centers, so that, and help establishing a ECMO over there. So they are ready to come over here. Actually, 3-day course, but as I have requested my senior, so for a better discussion and better hands-on, I have requested for a 4-day program, so that everyone will benefit from that. So that part can be taken care of. So a 4-day program will be there. The price will be much less than maybe what the general price is, and if we can work out, that will be a very good program, because the people are known to us. so that we'll get a better hands-on and a better improvement in our skills. And you can have a very easy talk with the persons, not like another person wherever దగ్గరికి వెళ్ళి ఎవరో తెలియని వాళ్ళని అడగడానికి it's a difficult thing, rather than our people coming and teaching us. So this is the plan. If we can work out with the people and finances, we can make a program better.
ఇది కాస్ట్ ఎంత శ్రీనివాస్ 85?
సార్ అంటే 40s తీసుకుంటుంది 85,000, లాపిటీ ఇచ్చి 1,25,000, 1,30,000 విత్ 1 year ప్రయర్ బుకింగ్.
కాదు, మనకి ఇప్పుడు వచ్చే ప్రోగ్రామ్
మనకి ఇప్పుడు వచ్చేది క్లీవ్లాండ్ సార్.
అది ఎంత
కాస్ట్ అంటే మీన్ ఫైనాన్సెస్ ఇంకా ఫైనలైజ్ అవ్వలేదు. Probably I can say around 60 to 70 for a 4-day program.
This is better, no?
So basic గా ఏంటంటే what is the topics he is going to teach, what is the especially hands on training ఏముంటది అనేది మనకు కంప్లీట్ ఎజెండా కావాలి.
సార్ ట్రైనింగ్ విల్ బి యాజ్ ఎ జనరల్ ప్రొసీజర్. మీకు క్యాన్యులేషన్ దగ్గర నుండి మెషిన్ రన్నింగ్ దగ్గర నుండి అండ్ ట్రబుల్ షూటింగ్ అండ్ మెయింటెనెన్స్
అవన్నీ ఉంటాయి. బట్ వి నీడ్ లిటిల్ హ్యాండ్స్ ఆన్ ఎక్స్పీరియన్స్. అంటే సపోజ్ క్యానులా అని ఇప్పుడు మనం ఏంటంటే థియరిటికల్ గా చదువుకోవడము డిఫరెంట్. మన క్యానులా అని కొంచెం ఐవీసీని
we have to get at least 1 to 2 mannequins as per our availability, and mannequin మీదే ఉంటుంది. And there is a software that is available with Mackie, which is an ECMO simulator software. సో మనిషి మీద పెట్టేటప్పుడు ఏటైతే మనకి మన వెంటిలేటర్ సిమ్యులేషన్ ఎలా ఉంటుందో సేమ్ దేర్ ఇస్ అన్ ఎక్మో సిమ్యులేషన్. ఓకే, సో ఆబ్వియస్లీ ఇట్ విల్ బి ఎ డీటెయిల్డ్ ప్రోగ్రామ్. నాట్ అంటే జనరల్ గా పెట్టే మామూలుగా ఎక్మో కాన్ఫరెన్సెస్ లా కాదు. ఇట్స్ నాట్ ఎ థియరిటికల్ ప్రోగ్రామ్, ఇట్స్ ఎ హ్యాండ్స్ ఆన్ ప్రోగ్రామ్.
ఓకే, ఎంతమంది ఉండాలి మినిమం?
సార్ 15, అంటే 15 కన్నా ఎక్కువ కూడా ఉండకూడదు. దే స్పెసిఫికలీ సెడ్ దట్ ఇట్ ఈస్ ఓన్లీ 15, మాక్సిమం ఆఫ్ 15.
15 అంటే
I think you can book my name, Srinivas name. ఏమన్నా
నాది కూడా బుక్ చేసుకోండి.
I am ready. Finalize the price and finalize this Cleveland, Srinivas.
సార్ వాళ్ళ సైడ్ నుండి వాళ్ళు ఓకే. అండ్ మెయిన్ ఏంటంటే వాళ్ళ అంటే నిన్న నాకు వచ్చిన what I have informed to them is like వాళ్ళ సైడ్ నుండి ఏంటంటే if you get the machine and the logistics, we'll finalize the dates.
Okay, because India, I heard this ECMO in COVID. In India, in the second wave, the mortality was outcome was only 40 or 45%. In the first wave. In second wave, it is only 30% throughout India. So their outcome is almost 90%. That is very good.
It is true, and I have seen the real videos.
Yeah, that's why this is better.
And we will see second wave we all know that because of loss of shortage of beds, shortage of manpower.
Yeah, whatever the reason, anyway, their outcome is very good, so that we can finalize this.
No, just may not be an exaggeration. Just I wanted to add few points. The usage of antibiotic in their ECMOs, like patient on ECMO, the usage of antibiotic is only 15 to 20%, and their infection control is that great. And they have seen only 2 Candida auris in last 5 years. So their protocols are so strict and so good.
That's why that is better to have. Okay. Yeah, once everything is over, we will